Hi, I'm Dr. Poole, and this is a presentation just to review some of the microscopic and gross features of some of the entities that are discussed in the study guide. This is just to reinforce with pictures the details that were outlined in the text. So first of all, let's just look at normal thyroid gland just for comparison. Notice that the follicles are filled with colloid, and the cells lining these follicles, called the thyroid follicular cells, or sometimes they're called thyrocytes, are flat or cuboidal cells, evenly spaced. Notice that the intervening interstitium between the follicles just has blood vessels and very sparse inflammatory cells and fibrocytes. So the parenchyma of the thyroid gland is really composed of thyroid follicles with a delicate supporting fibrovascular network. These are the entities that I'm going to go over in more detail with regard to the microscopic features in particular. Hashimoto thyroiditis, granulomatous thyroiditis, Graves' disease, and multinodular goiter. So let me summarize the microscopic findings in Hashimoto thyroiditis. Grossly, the thyroid is often diffusely enlarged, but sometimes it can be more localized. The capsule is intact and it's well demarcated from the surrounding tissues. Microscopically, the key finding is extensive infiltration of the parenchyma by a mononuclear inflammatory infiltrate that typically contains small lymphocytes, plasma cells, and lymphoid aggregates, sometimes that have well-developed germinal centers. The thyroid follicles are atrophic, and in many areas they can be lined by oxaphyll, also known as Hürtel cells, which are cells that replace the normal thyroid follicular cells and are obvious because they have abundant eosinophilic granular cytoplasm. Finally, you can see interstitial fibrosis. And sometimes this can be abundant and dominate the histologic picture. So this is a characteristic area of Hashimoto thyroiditis. The inset is normal thyroid gland for comparison, and you can see that there's really extensive loss or atrophy of the thyroid follicles. They're really difficult to pick out because there's such an intense mononuclear inflammatory infiltrate. You can see the dense strands of collagen fibers along the corners of the image, and this is some of the interstitial fibrosis that you see. So let's look at a little bit higher power for more detail. The intense mononuclear cell infiltrate actually obscures the remaining atrophic thyroid follicles. So I circled some thyroid follicles just to point them out because it's difficult to actually pick them out. So the main thing is in Hashimoto thyroiditis is this intense lymphoplasmacytic infiltrate. This is just a more higher magnification of the same image. Again, I circled the atrophic thyroid follicles. Note that there's no colloid in these follicles at all. And the infiltrate in between, I think you can pick out plasma cells and lymphocytes. And finally, the collections of Hürtel cells or oxaphyll cells are encircled in the blue outlines. Again, notice that the follicles themselves are atrophic, but they appear more plump because of these oxaphyll cells. The arrow points at one in particular. Note that there's voluminous eosinophilic cytoplasm, so they really are distinguished from the normal follicle cells, which are flattened or cuboidal. Okay, let's next look at granulomatous thyroiditis. Grossly, the gland can be either unilaterally or bilaterally enlarged. It's usually firm because of all the inflammation and may adhere to the surrounding structures, which is why it's associated clinically with neck pain. Histologically, the changes are patchy and depend upon the stage of the disease. Different histologic stages can sometimes be found in the same gland, which suggests that there's waves of destruction that occur over a period of time. In contrast to other forms of autoimmune thyroiditis, this presents more acutely, usually over a matter of weeks or a month or so, rather than over the course of many months. Early on, you find neutrophils, which form microabscesses, but the characteristic changes are aggregates of lymphocytes, activated macrophages, and plasma cells that are associated with damaged or disrupted thyroid follicles. And commonly there's multinucleated giant cells that enclose fragments or pools of colloid. And so that's what gives it the name granulomatous thyroiditis, although typically you do not see well-formed granulomas. Then later on, as this process kind of burns out, you're just left with a nonspecific chronic inflammatory infiltrate and a lot of fibrosis. So let's look at an image of this. So this image actually shows kind of early and intermediate stages in the same image, and the red circle shows a collection of neutrophils. I think if you look closely and compare it with the mononuclear or activated macrophages in the blue circle, you'll see that the nuclei in the red circle are dot-like or have small lobes, and just to convince you that they're neutrophils. The multinucleated giant cells ought to be obvious to you. And then the blue circle encloses activated or epithelioid macrophages. Again, in granulomatous thyroiditis, there are not well-formed granulomas, but it gets its name because of the collection of cells that form typically granulomas. Okay, next let's look at Graves' disease. Grossly, the thyroid is usually diffusely and symmetrically enlarged due to diffuse hypertrophy and hyperplasia of the thyroid follicular epithelial cells, which we'll see in a section. So the cut surface is actually kind of an exaggeration of the normal thyroid parenchyma. It has a soft meaty appearance that resembles, in some respects, skeletal muscle. Microscopically, the follicular epithelial cells are tall and more crowded than usual, and this often results in the formation of tufts of epithelium that project into the follicular lumen. The colloid within the follicular lumen is described typically as more pale than normal and has scalloped margins at the interface between the colloid and the lining follicular cells, and that's a key microscopic feature. Sometimes you can see lymphoid infiltrates. Commonly these have germinal centers, although it's usually not as prominent as Hashimoto thyroiditis. So I put an insert of normal thyroid gland in the lower right-hand corner for comparison, and note that the follicles show some variable dilation, and then the blue arrows point to these epithelial tufts. So if you think of the thyroid follicular cells being hyperplastic, they eventually crowd each other and then project into the lumen in these tufts. This is just a higher power view of the same image, again to emphasize the epithelial tufts and also show in higher detail this feature of scalloped margins of colloid in the follicles, and it kind of has this bubbly or scalloped appearance at the interface of the colloid and the adjacent follicular cells. Finally, we'll look at the morphology of multinodular goiter. There really isn't too much microscopic difference between diffuse and multinodular goiter. In diffuse goiter, the gland is diffusely and symmetrically enlarged, while in multinodular goiter, you have an asymmetrically enlarged multinodular or multilobulated gland. In multinodular goiter, the follicles are colloid-rich and lined by flattened inactive epithelium. sometimes you can see areas of follicular hyperplasia. The main feature of these is that they're markedly enlarged. So this gross image shows two of the features. Number one, the asymmetrical enlargement, the way that the specimen is oriented. The side facing the viewer is anterior, so you can see that there's asymmetrical enlargement of the right lobe compared to the left. And then you can see over the surface this multinodular appearance. And finally, microscopically in multinodular goiters, there's frequently variably dilated follicles. They're collagen-rich, and they're lined by a flattened inactive epithelium. It's actually somewhat difficult to recognize the thyroid follicular cells at this power. So I hope that helped illustrate some of the morphology from the study guide and the reading material, and reinforce some of these ideas about distinguishing these significant entities. Thanks.